I'm very, very happy to be here for this webinar and to welcome Alessandra Ferlini. So Professor Alessandra Ferlini is the director of the Medical Genetic Unit at the University of Ferrara in Italy. She's also the chair of the genetic group at the EURO-NMD. And as most of you may know, she's also one of the coordinator of the Screen for Care Consortium. So a very active geneticist trying to move on and move forward a very important field, which is newborn screening. And so today, that's really my pleasure to welcome Alessandra for this presentation, which will focus on a specific kind of newborn screening, which is genomic newborn screening, which, as the title suggests, will be a gateway for genomic medicine, but also with a lot of implication, both, of course, scientific and medical implication, but also at the ethical, social, and regulatory levels. So, Alessandra, I'm very happy to welcome you and really waiting to listen for you.
Thank you so much. Thank you, Alessandra. It's a pleasure to be introduced by you. Of course, we know each other from a few years and, great experience working together. And thanks to Elizabeth for organizing this webinar. So as anticipated, I will try to present you what genomic newborn screening is and why it is so important, as the title says, as a gateway to genomic medicine, because of course the future medicine, and there is a large agreement on that, will be definitively based on genomic knowledge. So genomic information, what our genome will tell us, in terms of disease susceptibility and disease diagnostics, and of course, with the final aim of being, of have therapies, access as soon as we have, hopefully, therapies for majority of rare diseases. And then also I will summarize some important issues related to genomic newborn screening, which are ethical issues, especially privacy issues, and all issues related to data storage. So let's go ahead. And okay, sorry. Right. Disclosure, I do not have any disclosure for this talk, so that would as a very quick slide. So basically, topics I will face are just presenting newborn screening, so a little bit more in a quite concrete way, so numbers, ethical and privacy issues, and how the next generation sequencing revolution, so the genomic data available, basically impacted on the very quick change and challenging of genomic newborn screening for rare diseases. Key question for all genomic newborn screening, irrespectively from the methodologies that we are going to use, is which are the diseases, the genes that should be tested in genomic newborn screening. Overview about some main, not all of them, initiatives related to genomic newborn screening, and of course a look inside the first results of a Screen for Care project, and then open issues, some considerations and questions from you. Basically, just an important point to the very beginning is that we have to keep in mind that screening is not diagnosis. Please keep this concept very clear for you all, because although we may use a similar technique or method or strategy to approach the diagnosis and screening, these are very different, because of course a diagnostic test is a test aiming at identify a specific genetic alteration in a person with a pathological phenotype, so with a disease, or at high risk of a disease in terms of pre-symptomatic testing. Example, diagnostic tests for disease diagnosis, confirmation of phenotype-genotype correlation, and therefore that all together mean that diagnostic grade is an important characteristic of the diagnostic setting. So having a very high accuracy and very high sensitivity. But the screening test is not the same, because when we are going to screen, we are not screening single individuals per se, but we are screening a population of individuals who are sharing similar characteristics. For example, individuals that can be a risk, let's say prenatal screening, let's say cancer screening for at risk population, thalassemia screening, where this thalassemia is an endemic disease, and so on. Therefore, this is not directed to an affected person. Important to remind. And of course, newborn screening belongs to a screening test. And therefore, it defines a risk and not a diagnosis. Therefore, screening and diagnostic tests have different aims, pipelines, and numbers. And this is quite important, as you will see in the next slides. Going back to the newborn screening story, so we are now in 1968, when Wilson and Jungner were the first clinicians basically formulating criteria for population-based screening, so metabolic newborn screening. And you see here the 10 famous points and criteria, principles from Wilson and Jungner, which are based on, as I said before, condition should be underlining a very important health problem. Natural history should be quite well known for the disease. The disease should be recognizable at very early symptomatic age. Suitable test must be available. The test should be acceptable by the population. This is sort of a little bit old-fashioned concept now that we are, of course, coming from years and years of metabolic newborn screening. So obviously, people is very well aware about screening. Parents are well prepared to receive newborn screening. And then, of course, policies, accepted treatment, facilities that should be in place to making available both the testing and also the treatment, cost benefit, which is a very common issue in all the medical, scenario, and of course, case funding that should be considered once and for all in the newborn screening approach. But today, we have more experience about newborn screening, and we have something more even important, and then we are in the position and in the situation to start revising these criteria. Why? Why is very simple. So because there are novel therapies for rare diseases available, we have, observed truly a flowering of therapies for rare disease. We hope that this number might be increasing in the next years. And importantly, we have the new techniques, so high throughput genetic strategies, which are based on, we will see later more in detail, several methods that can sequence many disease genes in the same experiment. So we are now behind metabolic diseases because our next generation approaches can be applicable to theoretically all rare diseases where the genetic defect has been defined. And that step forward, of course, we have some issues that we have to consider as the big issue of VUS, so variant of uncertain significance, which are now a complete unknown for the moment, and we have to find a way to get into the meaning, the true meaning of these variants, but also considering for newborn screening, penetrance and carriers. So shall we or not communicate carrier status to the parents, because that might be a very important, information for disease prevention somehow. So under debate. false positive and negative, which is also applies for metabolic screening. But very important, the turnaround reporting time, because now we are using, you know, more demanding techniques, which require more time than, but still we have to provide a report for the screening quite in time in the so-called therapeutic window for getting patients access to the specific therapy. And very important are costs and number of samples that we have to run, and therefore possibly and hopefully platforms that should be used for the screening. And for issues related to other, you know, non-technical, let's say, factors are the ethical aspects, the data ownership, the data storage, and the privacy rule. Therefore, all considering all these points, like somehow well established, pending, and to be sorted, we are basically approaching universal genomic newborn screening, which will impact on 95% of healthy babies. So this is the number that we should consider, and will identify roughly, because we do not know yet, of course we will know hopefully soon, around 5-9% of diseases amenable, as we hope, of therapies and treatments. And just to show you the dimension of newborn screening in Europe, because of course we are in Europe now, well, you see why the European Union and also the European Parliament have, so, robustly stressed the importance of two concepts for children health, which are equality and equity. And this means that all children in Europe should basically benefit for the full potential of health and well-being tools, as is illustrated in these two pictures, as you see here: equality, the correct, health being proposed for the children for the correct age, and the same full cohort of approaches for all children. So there are two different concepts. And they have also write two important statements, basically explaining, so describing the EU strategy for the children's rights, including obviously health being. Just for you, if you like to read it, they are very, very interesting, and are the pillars on which we should basically build up also the newborn screening scheme for the future. However, we are quite far now in Europe from that, very far, because this is not true, not at all, as you see here for newborn screening, which is based on heel prick test, so blood from heel prick by the second day after birth. And then you see the huge differences among countries. So Italy is the number one, so the top, let's say, top recruiting, so with 48 diseases, and more are coming in the next months. And then just the list, not to have a sort of classification, that's not the meaning, but to show the differences among countries. So meaning that babies that are born in Greece, for example, can be screened for only 4 diseases compared to babies which are born in other country. Sorry, I don't know what's happening. Okay. And this is also reflected by the same, you see here, the specific test offered for each diseases in the various countries. In some cases, you see the green arrows. You see here that in some rare, for a few diseases only, genetic test is entered into the routine newborn screening, as for example SMA, so spinal muscle atrophy, which is quite close to our ERN and neuromuscular diseases. Don't know why. I'm sorry. I have to switch on my mouse. Okay. And that, apologize. Okay. And now it will work. It will work. Okay. And then also for other SHID, as you see here, and also for the cystic fibrosis. But of course, These are really a few examples, and also based on specific, so single gene genetic testing, and certainly not based on next generation sequencing. So we have to work on that. We have to find a way to, work with all regulators, policymakers, patients association, and companies as well, because companies contribute is so important for rare diseases to have this situation a little bit more homogeneous. And then we have to be prepared in case we are able to offer universal genomic newborn screening to all European children, to provide this newborn screening to 4 million babies per year, which is a huge number. And of course, this cannot be offered based on jeopardize, situation as a single center, small centers for screening. We need obviously centralized approach, high qualified platforms, and synergistic initiatives to make this universal newborn screening, really a true possibility for all European children. And you see here just the reference networks and the distribution of population among ERNs. Of course, EURO-NMD and Ithaca, we know, are the top one in terms of patients, which are followed now from the ERN. So, of course, ERNs should be in the heart of this process, in participating to the newborn screening process, and of course, in taking care about the positive babies for all the standard of care and possibly the access to therapies. For the ethical issues, basically, we are somehow quite in a good situation, so we do not have to invent nothing, basically, because there are updated ethical guidelines coming from the World Health Organization, so WHO, which govern the ethical principles for genetic testing. And obviously, this is something that should be discussed to be applied also to genomic newborn screening, but the principles are quite well defined. So autonomy, which means that, of course, self-determination for genetic newborn screening is necessary. Obviously, in this case, parents play a very important role, and that's should be discussed later on. Beneficiency is obvious, so we have to have a benefit from the screening test, which is easy, can be access to therapies, and could be also making more actionable the disease that we are picking up. So that's a very, very big discussion, and we can stay on that a little bit later. Avoiding malefficiency, which is also obvious, so nothing can be done which may somehow harm the babies or the families. And justice, which is the last principle added by WHO recently. And then justice is basically treating the people and the person with fairness and equity. And this goes again to the European Parliament Declaration for the Children's Right. Okay, but why? Apologize. And therefore, the legal privacy issue, well, we are not in a very defined, clear situation as for the ethical issues. So many issues are not addressed. The first one is the ownership. So ownership of data, which is so important. Also for the last point of this slide, you can see here, because basically, as I said before, 95% of baby will be healthy during the newborn screening. So, but in any case, we have data from them. So who is the owner of this data? Because the point is that if we apply genomic newborn screening as a universal screening in European children, it is obvious that the genome of our children is also an heritage. Indeed, also the UNESCO has defined the human genome as a sort of heritage of the humanity. And therefore, it is very important to find a way to study, to use and reuse this genomic data for research, for, making to improve, for example, our therapies, to have more drug repurposing approaches, many things that we can do. But to do that, we need to define ownership and then how to access to this data from who might be interested to, propose studies, research approaches, and so on. This has not been defined, needs to be urgently addressed. Same for data storage. Data storage is super important. We know that, for example, if you list the people participating now are from ERN, we have now mandatory for all ERNs a registry work package, because registries are exactly the space where these data are recorded, are kept, are stored. So still, same approach we should try to pursue for newborn screening, where our data will be stored. We need safe storage, secured. This again needs to be urgently addressed, because we will have a lot of data from our children very, very soon, thanks to the various European and not only European newborn screening initiative. And then, of course, the GDPR compliance for the privacy must be met. That's quite, immediate, because the rules established by the GDPR are clearly explained in the EU GDPR regulation, and that should not be an issue if you are basically strictly adherent to the GDPR rules. And you see here what the newborn screening plan means also for the European Union. And obviously, the two issues of ownership and data storage should be, that it would be super important to start a true discussion, especially with the regulators and policymakers, about these two issues. Very quickly about methodologies. Of course, methodologies are important, but are not so important because they are working quite well. So we have already next generation sequencing techniques available for more than 10 years, so 15 years. And, all of them are completely suitable for being used in a diagnostic setting and as well as in the newborn screening setting. And of course, based on these techniques, we have, of course, challenging issues which are well known. So we have to face what we call output, so number of sequences of variants that we can have from our methods, which might be huge. Look for the whole genome sequencing here, quite huge, more than 3 billions of bases in the target, expected variants 3 million or 30,000 for whole exome sequencing, and of course much less for panels, for example, small or large panel. And this is important because output requires time, requires variant interpretation, and requires a lot of attention for the type of variants. For example, the copy number variations and dynamic mutations, which are causing many rare diseases, which are not at the moment identifiable using these techniques. And then also we have different genotypes that should be also considered in newborn screening approaches, in genomic newborn screening. For example, double contribute from two different genes in a phenotype, so digenic inheritance, or the occurrence of mosaics, which can be identified using NGS approaches. And of course, mutation load, which is also quite a complicated issue, more related to polygenic traits, not Mendelian diseases. And obviously, how to set the pipeline for reporting. So reporting for VUS, or reporting or setting follow-up functional studies to understand what these views can mean in terms of pathogenic significance. Just example of the various strategies very quickly. You can see here the pros and cons of using gene panels, whole exome sequencing or whole genome sequencing as method to be used for genomic newborn screening. So of course, gene panel, which means targeted sequencing, so sequencing only a few genes, a group of genes, might be more than 300 genes, classically. And you have, of course, a design of the panel and the usual approach, sequencing run. You see that you may have, roughly 1,000 variants in the average. But the added value for this approach is that you do not need to validate the variants because you have a very high coverage, very high quality of the reads in your panel. You don't have incidental findings because you are just, of course, looking at the genes you are interested in, and you have an excellent cause for all variants, so both the small variants, both also copy number variations, but of course not the triplet diseases or dynamic mutation. The report turnaround timing is quite good. 1 week. Very similar is whole exome sequencing. The difference, of course, is you are using a type of gene enrichment, as we say, including the whole exome or the Mendelium, as we say. Of course, you can analyze in silico, so basically on the whole output, on the full output, the genes you are interested in, so maybe 300, 400, 1,000, doesn't matter. Validation, however, here is mandatory because WES is not such a in-depth in terms of REDS coverage. But variant calling is excellent for small variants, good for copy number variations, but again, not possible for dynamic mutation. And turnaround timing is very similar to panel analysis. And lastly, which is without any doubt the future of our medicine, is whole genome sequencing, which has a very large output, of course, but can detect basically all variant types, so the small variants, the copy number variations, and perhaps in the future, using new algorithms, we may also pick up dynamic mutations. Of course, the output is quite big. Again, you can interrogate, you can just check the genes you have chosen, so it's the same as the whole exome sequencing or even panel if you like, and probably turnaround timing might be a little bit longer, but there is a lot of improvement also in this step. So whole genome sequencing will probably have the possibility to be reported really in 1 week, like for the other methods. Just to show you the methods again, I like to show you that as an overview, and again underlining that we can choose panel, we can choose whole genome sequencing or WES, but that's not so important in terms of genomic newborn screening output, which we will go through that in a while. Very quickly, just I like to have a spot for the role of medical geneticist, which is super important to analyze the newborn screening output and the output analysis. So please remember that we have a role in this process as a medical geneticist, and also obviously similarly role have bioinformaticians who are called to analyze all this output from our panel or exome whole genome sequencing data. So two figures, two professionals which are super important for the genomic newborn screening. Then quickly again, just underlining the important, because we are probably going to have, sort of platforms or, centralized activities for newborn screening, the telemedicine, so the possibility to have, telegenetics, telemedicine, teleconsultation, virtually with patients which are far from the expertise center is very, very important for somehow granting all rare disease patients to have an outstanding and excellent counseling related to the specific diseases, which cannot be, just around the corner all the time. And then going to the Screen for Care, probably many of you know this project is a funded EU project. I'm so happy, honored to be the scientific coordinator together with Pfizer and Aldona Zygmunt, who is project leader representing FPA colleagues, so the European Pharma Company Association. And the projects will basically start in October 2021 and will run until October 2027, because we will probably very likely have 1 year of extension, so 2027. 14 countries, 35 partners, and a budget quite remarkable, which comes 50% from European Union and 50% from the direct contribution of our FPA partners or from the company. You see here the very large partnership of Screen for Care, composed by academics, Ferrara, Bambino Gesù Hospital, and Max Planck Institute, and many others, University College of Dublin. But together we have many companies. We are very happy to work with them, like Illumina, Roche, Sanofi, Novartis, and PTC Therapeutics. And you see the many of them. There are both companies involved in vitro diagnostics, but the majority are involved in drug development, which is so important, of course, for all of us, in order to try to implement, to increase the available therapies for our babies, with our children with rare diseases. And this is the Screen for Care Consortium. In this consortium, we have the voice of patients, fully involved as a partner. And that there is EURO-NMD. EURO-NMD is representing the rare disease associations in Europe, and EURO-NMD is a partner that participates to all the process, co-creating, co-designing the various tasks, and is involved mainly, of course, in genetic newborn screening pillar, but also in data repository collection, and also in the meta symptom checker, which is the digital work package of Screen for Care. So it's so important for us to have, the voice of patients directly into the project, to work with them and to share all the, project details and steps. This is the structure. I will go through that quite quickly. I can skip that, to be very honest. It's a typical structure of EU project, just to point for you where newborn screening is, because Screen for Care is not only newborn screening, but newborn screening basically is part of Work Package 3. And then this is exactly what we are going to speak now. So the two souls of Screen for Care are genetic newborn screening from one side and digital solutions from the other, which are quite important as designing for a common frame for electronic health records, basically across different countries, which will be very important for, the future establishment of the European health data space, which is a EU initiative just started in October 2024. And then to develop the Screen for Care platform, virtual platform, basically, that could serve as a, symptom checker provider to facilitate the identification of the correct diagnostic path for rare disease patients. For newborn screening, basically, this is what is composed now in Work Package 3. You see, we have already started our newborn screening pilot study using a very innovative tool, which is called the Treat Panel. So basically, we are using, as I showed you before, a panel, so targeted sequencing. This is called the treatable. We also will run a pilot newborn screening based on whole genome sequencing. This is quite new, so happy to share that with you, thanks to the collaboration with also our partner Illumina. We also will have whole genome sequencing in early symptomatic babies according to the project description. And also we are piloting some new algorithm for electronic health records and also piloting some new imaging approaches for muscle diseases. So these are basically the main research approaches now ongoing in Screen4Care. Just a key question that might be useful for the discussion after the webinar is just doesn't matter the method we are going to use for genomic screening, not so important, but the point is which are the disease, the genes that we have to analyze and that should be reported in genetic screening. Is it possible to find an agreement, find a consensus about these genes, to have a core list of disease genes? And to do that, how it is important to cooperate, to network with other initiatives. And this is why we are within as many initiatives, newborn screening initiatives, are part of ICON, so the International Consortium for Newborn Sequencing. This is an initiative basically promoted by some US colleagues, including Reddy's Children, San Diego Hospital and Boston University. And then within the ICONs, what we have done, we used a few gene lists already prioritized in other projects. These are two examples. So this is exactly the US initiative Beginning GS, which is quite famous. It's basically led by Stephen Kinsmore in San Diego. And basically what they've done using rational and the process and algorithm, they have prioritized 295 genes, group A, and 93 genes of group B in terms of importance and somehow prioritization for being screened. And then basically this is an example of one of the first gene list to be screened by newborn screening. Similarly, the BabySec project is done in Boston, led by Robert Green, and they also have selected in a few infants a very long list of genes. You see the number, basically more than 4,000. So you see how approaches can vary. We may have a very small number of genes or limited number, or we may decide to basically screen 4,000 genes, so all rare disease genes. So how can we somehow conciliate these two different views? So what we have done, as you see here, that's a very nice paper we have published together. We put together all these different initiatives. You see, here are the projects below. So Baby Screen, Beginning GS, here is Screen4Care is here, and many others from Australia, from Europe, from United States. And we have compared the list of genes and based on the different phenotypes causing, and we have basically tried to get a core list of genes. You see here, the yellow squares basically correspond to a small list of genes that somehow we can agree on in order to have a sort of common, baseline number of diseases that can be screened, possibly, hopefully, worldwide. That of course is a little bit a dreaming situation that I share with you, but at the end of the story, we might be able to have that, which will be an enormous advantage because we can have a very core list of diseases which are screened everywhere, and then of course providing important data for research aspects, policy data, and so on. And this is basically criteria used to do that were penetrance of the genes, expression, unique expression in terms of single phenotype, inheritance, being amenable of next generation sequencing detection, frequency of the disease, clinical validity of the test, and test sensitivity. all these criteria have been used. And this is what also we have done. See here the protagonist of this of the treat panel design, which are Jambel Kirchner from Freiburg, who is also World Package 3 coordinator, and Enrico Bertini in Rome at the Bambino Gesù, of course, together with many other colleagues in Screen for Care. They define the list of the treat panel based on the various lists already available, just to try to see which are the genes shared and commonly used in the newborn screening, and defining scores to be assigned depending, of course, on these criteria, so clinical validity, age at onset, disease severity, and penetrance. And at the end of the story, basically, we have retained 245 genes which are composing the treat panel through this important selection path that have been used for the treat panel. This is also published as the paper together with the ICONS colleagues. So if you like to have a look, please read these two articles. We hope you can find them interesting. So this is our treat panel that we are using in the Screen for Care, just to share with you that we encountered a lot of positive comments also from you, from the Parliament, from many other countries in Europe who are now would be happy to also use our treat panel as well. And these are the phenomics. So you see all the diseases, so mainly metabolic, because that's the majority of diseases with onset at birth or around birth in the neonatal period, but also many neuromuscular condition, neurological condition, some syndromes, and blood and coagulation disorders. And here represented in terms of frequency of the diseases. And just a point for the treat panel to cite, thanks to the colleagues from Roche. Roche is a partner of Screen for Care. As I told you before, we are working with industries. And Michela Zuccolo and Marcos Mialatos, they have designed the treat panel together with us. And this is a very innovative panel because it's also able to pick up regions normally not recognized by next generation sequencing, like the SMA genes, SMN1, SMN2, and all the SMN loci, which is so important for the newborn screening for SMA, which is now, of course, mandatory in some countries, not all, but in many countries in Europe. So we will be able to pick up also SMA babies and also define the SMN1 and 2 copies, which is very important. We got through the ethical application, and I'll stay into detail. We got ethical application for the treat panel in all countries involved, which are these are the inclusion criteria in our trial. Our trial has been registered in clinicaltrial.gov because it's a retrospective clinical trial. And then these are our recruitment rules, so competitive, and then type of variants we will consider, of course, not VUS and not benign polymorphism. We produced a lot of material. You can find that on the Screen for Care website, video in English, in Italian, flyers explaining Screen for Care in many languages, include Arabic, Turkish, and many others. Same for the frequently asked questions in many languages. And so we will try to maximize dissemination of Screen for Care. As anticipated, because we are going to screen 18,000 babies in Europe, we decided to centralize the sequencing. And this is an issue that we would deserve to be discussed for the future health translation of newborn screening, genomic newborn screening. So all samples will be shipped to Bambino Gesù in Rome. Bambino Gesù in Rome is the larger Italian genomic platform available for running whole genome sequencing or treat panel sequencing and generally sequencing activities. We have a dedicated DBS card that has been designed by Revity, and of course a dedicated registering system for the babies, which is digital, in order to have, all babies properly registered and the entry site in our system. And then, of course, this is the sequencing flow chart. So you see here from our the dry blood spot card, you see the dot blot, the blood here. This will be extracted directly from an instrument. That's why it's so important to have a platform working on that. The same automation for DNA extraction, and then of course the same for all the library setting and the sequencing procedure. And then of course Screen4K data will be analyzed by, again, centralized activity provided by two bioinformatics centers like Genox and SINAG in Barcelona and Amsterdam, respectively. This is the very complicated, apparently, but I know this webinar is recorded, so if you are happy, you can go back to that and go into detail. I don't want to stay so much on that. This is just our pipeline to ensure that the flow of samples, of information will go on correctly and properly. Just consider here this lane, which is the Screen4Care lane. So what we are going to do within the Screen4Care project, Screen4Care is a research project, will be ended in 2027. And then we have to ensure a complete follow-up for our positive babies. And this is why we have done a strong collaboration with all ERNs. We have written some operational guidelines. We have a paper now in preparation. And then ERNs are those centers, the excellence for centers for rare disease in Europe, that should basically take care about our positive babies and put in place all the standard of care necessary for our babies. And then this is the first results I like to provide you. So you see that the treat panel is already in place. And then we have already working a few centers. So 2 in Italy, in Germany and in France. And there are also some other centers coming. You see the data here. So basically, we have already informed close to 3,000 families for the Screen4Care. And we have collected 2,500 cards, meaning that we are going to analyze all of them. We have a relatively high number of reviews. This is an average among all centers considered for this number, which are Ferrara, Rome, Modena, Dijon, and Freiburg. Okay, while other centers will come, so Parma in Italy, Brno University in Czech Republic, Thessaloniki in Greece, and the rest of university from Poland. They will join in the screening process. And then still this refusal looks to be high, of course, but obviously our approach is quite novel. So we have to work on that and provide lots of lots of information to couples in order that they can become familiar and, basically trusting the importance of genomic newborn screening, which is not metabolic, of course. And then this are the final number. I cannot disclose specific results, unfortunately, but data are quite encouraging. You see samples completely finalized after sequencing are more than 1,500, with 65 positive babies identified, which are 4.2%, and which is already something, because it's quite intriguing. Of course, we needed to check more babies. We should have more data, but this is already something that is completely unexpected, because this is not what we would expect from rare diseases. So encouraging, just keep on and going on and try to get final results, and of course negative, all the rest. And in terms of conditions identified, we identify 19 dominant, 14 recessive, 18 X-linked condition, and 14 with a dual inheritance, which is a little bit of trouble, but I will leave that for questions later on. Of course, This is an issue that we are facing. Screen4Care is a research project, so we have to learn from what we are doing. And these dual inheritance phenotypes are a little bit troubling in terms of being somehow considered for newborn screening. And also we have a very frequent variants I can already anticipate. So for example, the SAPD or the sodium channel 4A, which are very frequent in terms of carriers in the population. So think about it, we need to think about it. And that's it. I would close here because there is something about digital health, but because I don't want to run over time, I will leave that for eventually questions later, and I will skip that. And just at the end, we have many reflections. In green, we are fully okay for the ethical issues. Everything is clear and in place. But that's not the case for ownership. That's not the case for data storage and data sharing, which are all issues which needs a lot of attention. And we hope to be able to demonstrate and provide evidence that schemes or more than one scheme of genomic newborn screening might be really a sustainable offer to be adopted for our children in Europe. And thank you very much for your listening. And leave you, Alexander, for discussion.
Yep, thank you very much. Very dense and rich presentation, but also very, very important as we see that's the next revolution in diagnosis, and also very important to be able to identify these diseases as early as possible, to be as efficient as possible in the way we can treat them. So for the people following the presentation, don't hesitate to write your question if you've got some in the chat. And I would say, personally, you talked about the current issue on storage, ownership. You referred to the GDPR, but you didn't refer to the European Health Data Space, which is the next legislation. Genomic data are considered as health data. So theoretically, they should be in this European Health Data Space, where theoretically there will be dedicated infrastructure to store this data. There will be common rules to share this data inside Europe. So hopefully these questions of ownership and storage will be solved. What do you think about it?
That's an excellent question, Alexandra. For the storage, yes, this is our hope. Exactly. So, and indeed, we are encouraging all newborn screening initiatives to get in contact to the European Health Data Space in order to make possible that research project data, for example, Screen4Care, but not only. For example, we were discussing that also with the Genomics England and many others, will flow into the health data space. So yes, I do hope that the European Health Data Space can be the answer for the data storage. Yes. Ownership is a very different issue because ownership at the moment is, to be very honest, quite undefined, because theoretically should be ownership should be in the hands of the parents of the baby, theoretically, right? But also this is a sort of eventual decision that might be not very, somehow very safe also for the baby, because there are many things that can happen in the couple, we know, of course. And then the first point, we are medical geneticists, so we are very familiar with this point, right? Separation, heredity, whatever else. So ideally, if we have an European health data space, so data storage is okay, we should think about a tutor, right? Who might be, or more than one, of course, like people in charge for secure babies' data, because we are talking about children. And that's my comment.
Yeah, no, I understand. And yeah, it's very important to remember that we are talking about babies. So people who cannot express any consent. And as you say, that means that this ownership has to be given to someone else. I also have a very naive question, because you highlighted the importance of counseling, genetic counseling. But actually implementing such programs means a lot of human resources, because you need to meet the parents, you need to ask them for their consent. And when you got positive results, you need to go back to the parent. Is the system ready to
Okay, no. That's we have a lot of discussion, especially with the French colleagues, to be honest. But that's fine. But this is important. You are French, so you can understand. So the point is, we have to get, in another dimension and not in diagnostics, right? As I said at the beginning. So screening is screening, diagnostic is diagnostic. So personally, I think that counseling, genetic counseling, is not required to collect informed consent. Okay, so we are still brainstorming on that. So I don't want to pass that for the correct opinion. Is just my personal opinion. I would like to underline that, but not only mine. So normally, also in Italy, for the newborn screening, you do not need an informed consent, because metabolic, right? Because this is part of the health program. So you have just go through that and having your heel prick blood sample, and you go home, and that's fine. So counseling is required for the post newborn screening. So if we think about screening in that way, we are ready, because we have counseling for positive babies. Yes, I think so. We may implement a little bit, but if we want to have counseling pre-testing, pre-newborn screening, that would be a mess, of course. This is still quite an argument, to be honest. I know that we are not all of us not on the same lane, but this is something that we should consider carefully, because otherwise we will be more genetic counselors than patients, and that might be not a very good idea. So, if I may say.
And I see we got a question in the chat from Joachim, and that was actually also the point I wanted to raise. As you talked about the actionable disease, for which it's quite easy to convince our government about the importance of screening this for this pathology. But we know there are also pathologies for which there is no treatment, but where we could expect that early screen and diagnosis could be beneficial for the patient. So the question from Joachim is the question more ethical or scientific and social when there is no treatment for some diseases that can already be screened? So is it more ethical or scientific and social at the moment?
Is ethical. Is ethical because if we are close to the WHO principles, which we have to, because these are the recognized ethical principles, the concept is beneficency. And beneficency is because, babies are babies and cannot have the autonomy, which is a point, as we've discussed before. Because if I would ask a baby, would you like to have actionable disease screen? And he would reply, yes, of course. This will be autonomy and everybody would be happy, and we can also screen actionable. But because this is not the case, right? And beneficency is not there because we, at least we do not have measures for measuring beneficency in children. This is the tricky point. The barriers are ethical, and indeed, for the Screen for Care example, the actionable panel of diseases has been rejected for ethical burden, because this is causing more burden than solutions. The challenge is for us, for all of us, for Patients Association, for all of us, is to find a way to make, to identify which are the benefits of newborn screening for actionable diseases. This is the key point. And as I share that also with you, or these friends, an important step would be go to WHO and presenting this issue and say, hello, people, now times have changed. Can we consider something else from the ethical point of view? So not only treatment beneficiency, but also other types of benefits.
Yeah, we know it's very frustrating because to get
Absolutely.
missing data, you need to do pilot, but to do pilot, you need ethical approval, and to get ethical approval, you need the data. So at one point, there's a solution.
I fully agree. That's our task now, Alessandra. So try to be creative, to be brainstorming, and find a way to move this on, to find another measure for actionable disease. And just forget about treatment, because if we go into the trouble of treatment, we will never get out from that.
Thank you very much. I think that will be the concluding remark. So thanks to all the people who attended this meeting. It has been recorded, so you will be able to promote it, and don't hesitate to disseminate it to your community, because I think it's a very, very important topic. And as it was mentioned as a concluding remark, there is still a lot of lobbying to be done. And thank you very much, Alessandra, for this very detailed and interesting presentation.
Thank you. Thank you, Alexandra. Thank you all. Thank you, Elizabeth, and it was nice to stay with you.
Thank you very much, Alessandra. Thank you, Alexandra.
Bye,
Goodbye.
Elizabeth. Goodbye.